All right. Well, welcome everyone. Today is, I'm going to try to keep it together. This is a tough day. Um, we sadly learned the news that two of our wonderful Owen colleagues will be leaving us in the next couple of months. Um, Darcy Wooten, who is not presenting, and Amutha Rajagopal, who is. So sorry, it's all been hitting me. But at least I get to introduce Amu, who's going to be giving us such an amazing talk before she leaves. And you'll hear a little bit about where she's going. So Amutha Rajagopal is an assistant professor in the Division of ID and Global Public Health here at UCSD. Her background includes board certifications in internal medicine, ID, preventative medicine, as well as in addiction medicine. She also completed a Master of Public Health. Since 2019, she has worked at the Owen Clinic as a primary care physician for a panel of about 250 people living with HIV, many with hepatitis C. The majority of her patients have a substance use disorder. She will officially be leaving UCSD to begin a new role at UCSF this fall as the Associate Medical Director of Ward 86, which is the largest clinic in the San Francisco Health Network for people with HIV, and to contribute to UCSF's expanding treatment programs for people who use drugs. We're so excited for you, but really sad. Sorry, I'm just having a moment. Amu, I will turn it over to you and I'll pay attention to the chat and let you know if there's anything, but hopefully we'll have some time at the end for discussion.
Thank you. Thank you, Jill, and thanks for almost making me cry now. But okay.
What I do.
Okay, so I'll just get started. So I'm presenting on updates on the use of buprenorphine for opioid use disorder today. I have no financial disclosures. My main objectives are to describe a few reasons to become comfortable with prescribing buprenorphine, review pharmacologic and clinical evidence for buprenorphine doses for opioid use disorder in our current illicit drug landscape, which is largely fentanyl use. I will provide evidence to support using different formulations of buprenorphine available for opioid use disorder and some evidence-based buprenorphine initiation strategies. So I'll start by showing this a well-known graph of deaths from different opioids over the last 3 decades. So the graph begins with prescription opioid use in the 1990s to heroin use in 2000s and synthetic opioid use, including fentanyl use in recent years. The year 2013, I put a red star next to because it was around that year that fentanyl was noted to become more prevalent in the illicit opioid supply. And since then, there has been a steep rise in opioid overdose deaths, as you can see with the blue line, dark blue line. So fentanyl-related respiratory depression was declared the #1 cause of death in an adult 45 years of age and younger in San Diego County, but also the same for the United States. So this graph shows fentanyl seizures throughout the US from the DEA. The size of the circles is proportional to the volume of fentanyl seized. San Diego Imperial County as a region is an epicenter for fentanyl trafficking in the country, which ranked second highest in the US for fentanyl seizures. So while we do not have the data yet regarding the prevalence of fentanyl use among patients in the entire UCSD health system, Dan Sweeney, our medical ICU director, did permit me to share this slide, which shows a rough estimate from our electronic medical record data of the number of people admitted to the UCSD ICU with a fentanyl positive urine drug screen in a year. So there were 715 people admitted to the UCSD ICU with a fentanyl positive urine drug screen from 2022 to 2023. So that is nearly 2 people admitted to the ICU every day. It would be interesting to see data regarding the prevalence in our emergency room. But about 5% of people who are admitted to our ICU were prescribed medications for opioid use disorder prior to their discharge from the hospital. Well, the presence of fentanyl in a urine drug screen certainly does not indicate having an opioid use disorder for which we use medications. So medications have long been the gold standard of treatment for opioid use disorder and have been supported for a very long time. Psychosocial interventions, while they certainly can have benefit, have a relatively limited impact compared to medications for the majority of people with an opioid use disorder. However, very important to offer, particularly after somebody stabilized on medications. Psychosocial interventions are therefore not considered mandatory for initiating medication treatment. So people who are on medications for opioid use disorder for 60 days experience a 60% reduction in risk of overdose. And this risk of overdose only improves with longer treatment duration. Inpatient treatment for opioid use disorder has been shown to increase treatment uptake and reduce the rates of patient self-directed discharge. However, in order to gain the most important benefits of opioid use disorder treatment, such as the significant reduction in mortality, hospitals need to ensure seamless transitions for people in the hospital to actually access outpatient treatment. A barrier that has been cited is the lack of financial incentives for hospitals to provide resource-intensive care navigation in the hospital in spite of the escalating death rates. Overall, the vast
I'm really sorry. I think it was about the slide from Dr. Sweeney. Dave Grillotti asked if they were unique patients. I think he was talking about that slide, correct, Dave? I think the question is, were those unique patients, or could those have been,
Oh, yeah. Yes, those are unique
Yeah.
patients. Those are unique patients, yeah.
Okay.
And the drug screen was collected after or prior to or at admission into the ER, and those fentanyls couldn't represent treatment with fentanyl because people were being,
in the hospital. It's on admission that he included urine drug screens from ER admission.
Yeah, Dr. Sweeney's very good about this, and these were not people who'd been treated already with anything.
He actually presented that at the critical care rounds a couple months ago, but I asked him if I could steal it.
Yeah, that's it. There were just a couple of questions related to that. Go ahead. Sorry, Amu.
Okay, that's okay. So thanks. That's a good question, though. So overall, the vast majority of people with opioid use disorder do not receive treatment in the US, 80 to 90% it's estimated. But the life-saving treatments have been available for decades now. All target the mu-opioid receptor, which is associated with the major reinforcing effects of using opioids, such as analgesia and euphoria. So mu-opioid receptor is the target of methadone, buprenorphine, and long-acting naltrexone, which are all of the FDA-approved options. The bottom line from this slide is that they all work, all of these treatments. Methadone, buprenorphine, and long-acting naltrexone, not oral naltrexone, have been shown to reduce death. All of the options in this table reduce illicit opioid use as well. Methadone has been approved since the 1970s for opioid use disorder. Suboxone and Subutex have been available since 2002. Long-acting naltrexone, or Vivitrol, was approved for opioid use disorder in 2010. And then importantly, oral naltrexone has not been FDA approved for the treatment of opioid use disorder, since retention has been found to be inferior with this option, and it has not been shown to consistently reduce mortality. Notably, none of these treatments were approved based on data from our population of patients who are largely using fentanyl. So this is a table for considering the pros and cons of different medications. Real briefly, buprenorphine and methadone allow for more rapid initiation since they are opioid agonists. They can also address pain. Methadone has the highest risk of causing an overdose since it is a full agonist at the mu-opioid receptor. It requires linkage to a licensed methadone treatment program and more frequent follow-up for patients, often multiple days per week, particularly initially. Any clinician who has a DEA license today can prescribe buprenorphine. Extended release naltrexone is more difficult to initiate, which limits its effectiveness because it is a competitive antagonist at the mu-opioid receptor, so it requires the abstinence from opioids for 5 or more days. But in those who do initiate extended release naltrexone, there have been comparable treatment retention with the opioid agonist options. So the reason I'm focusing exclusively on buprenorphine today is because all of us with a DEA license can start buprenorphine no matter where we prescribe from, whether it is in an outpatient clinic or in an inpatient setting. According to the Department of Health and Human Services from January 2023, the repeal of any special waiver for buprenorphine prescription has symbolic importance in recognizing that buprenorphine should be considered mainstream medical treatment. So for the rest of my talk, I'm going to be focusing on the evidence for choosing a dose, formulation, and initiation strategy, particularly with a patient using fentanyl or high-potency synthetic opioids. So why is fentanyl more dangerous than heroin? Fentanyl is more potent. It's 50 times more potent than heroin. And also importantly, there are even more potent opioids that are being used more prevalently, more frequently. Carfentanil is one of them, which is actually an animal tranquilizer meant for large mammals, such as elephants, and is 100 times more potent than fentanyl. But aside from having greater potency, fentanyl is also more lipophilic. This means it permeates the blood-brain barrier more easily. This leads to faster onset of central nervous system effects like respiratory depression. It also exits the brain more rapidly and has a shorter duration of CNS activity due to being lipophilic. And shorter effects incline people who use fentanyl to inject it more frequently. Even though fentanyl has a short half-life of 3 to 7 hours, due to its lipophilicity, it accumulates in fat tissues and gets redistributed from there back into the systemic circulation. So blood levels can climb with cumulative doses due to this fat storage. Also of note, even if someone stops fentanyl for a few days, they may have residual fentanyl activity on their mu-opioid receptors due to its redistribution from fat stores. So this results in a relatively unpredictable time course for fentanyl withdrawal signs and symptoms compared to other opioids like heroin. Importantly, fentanyl causes profound opioid receptor desensitization compared to heroin. It actually leads to the internalization of mu-opioid receptors from neuron surfaces, and it also downregulates the downstream intracellular signal transduction pathways from the mu-opioid receptor. So in summary, fentanyl makes us less sensitive to opioids, more tolerant, and more dependent. So how does buprenorphine work? Buprenorphine is a partial mu-opioid receptor agonist. This means that it has a ceiling in terms of mu receptor activation in spite of increasing doses. Its affinity, or the firmness with which it binds the mu-opioid receptor, is higher than for fentanyl and many other opioids. And these characteristics, the ceiling and the binding affinity, are characteristics that provide a clear benefit for preventing respiratory depression while a person is using fentanyl. There are a few studies I want to highlight today to illustrate the ceiling effect, which make it especially useful during a time of record deaths from overdose. So a study examining the acute effects of buprenorphine on breathing in opioid-naive healthy adults showed that there was a plateau in the depression of ventilation rate in spite of increasing doses. So you can see in the graph how ventilation rate drops with increasing doses of sublingual buprenorphine in the top graph, and then starts to plateau somewhere at a dose between 4 and 16 milligrams. The respiratory rate is maintained while sublingual buprenorphine doses continue to be escalated from 16 milligrams to 32 milligrams. Oxygen saturation drops from 98 to 95% with an escalation of dose all the way from 1 milligram to 32 milligrams. And this was a study done with opioid-naive adults. At least 2 studies have evaluated respiratory depression with co-administration with fentanyl and buprenorphine. So shown here is the effect of fentanyl alone on ventilation rate. So fentanyl doses are increased in the top graph with the blue line. And you can see that there's a higher percentage of mu receptor occupancy in the middle graph. And the lowest graph shows the ventilation rate plummeting with the increasing fentanyl doses. So after infusing buprenorphine intravenously, which is shown in red, there's an initial drop in ventilation rate in the bottom right, but then the ventilation rate plateaus, as shown with the arrow. So this is actually while buprenorphine is infused to a plasma concentration that occupies near 100% of mu-opioid receptors, which you can see in the middle graph on the right. As fentanyl is increased in blue to higher and higher doses, you can see that the ventilation rate does not change while buprenorphine is on board. Buprenorphine also has some other receptor targets that are thought to contribute to prevention of respiratory depression. It's an agonist of the nociceptin opioid peptide, or NOP receptor, which is associated with respiratory stimulation. It is an antagonist at delta opioid receptors, which also limits respiratory depression. Due to its ceiling effect on respiratory depression, there's recently also some evidence that it may even be a safe and effective substitute for naloxone in people with an opioid overdose. And then listed here for reference are multiple studies on deaths in association with buprenorphine, including autopsy studies, which have shown that death from buprenorphine has nearly always been associated with additional sedatives, such as alcohol and benzodiazepines, and not buprenorphine alone in adults. I say it's important to recognize that in pediatrics, there have been deaths in association with buprenorphine alone in young children. Another useful aspect of buprenorphine is that while a respiratory ceiling effect occurs, a ceiling for analgesic benefit is unknown. So prior to use of buprenorphine for opioid addiction, it was approved as an intravenous opioid analgesic in the 1970s in the UK and also in the US in the early 1990s. So initially used for treatment of pain. The elusive ceiling with analgesia may be because it also binds to receptors outside of the mu opioid receptor. So buprenorphine is also an agonist at opioid receptor like 1, which produces analgesic effects. It also acts at kappa opioid receptors as an antagonist, and kappa receptor agonism causes depression and anxiety. So kappa antagonism is a favorable effect from buprenorphine. Finally, buprenorphine appears to reverse some neuroadaptations from fentanyl use. It's been found to both upregulate mu opioid receptors on the surface of neurons and improve receptor sensitivity through impacts on downstream intracellular signaling. So we know that prolonged use of full agonist, mu opioid agonists can paradoxically lead to enhanced sensitivity to pain or opioid-induced hyperalgesia, and this can persist for several months, not uncommonly. Buprenorphine may be especially useful for people suffering from opioid-induced hyperalgesia due to its reversing neuroadaptations. The high binding affinity of buprenorphine also causes a phenomenon called precipitated withdrawal. And this occurs due to the acute receptor activation disruption when it displaces other agonists at the mu opioid receptors. And precipitated withdrawal occurs on the order of minutes. It's important to keep in mind that when we are treating a withdrawal state, however, in someone, for example, regularly using fentanyl, we're not usually just treating precipitated withdrawal, because we're also treating a larger opioid deficit that results simply from the chronic exposure to a higher potency opioid. And the deficit is greater with fentanyl than with heroin. So even spontaneous withdrawal, there would be a greater deficit to address. And this slide is really just to illustrate that. When we meet a patient in withdrawal with a certain withdrawal severity score as measured by COWS, we're only seeing a tip of an iceberg. So the opioid deficit for someone chronically smoking 80 to 90 fentanyl tablets per day is much larger than someone using heroin. And the profound difference in tolerance impacts what doses of opioids we use to treat the withdrawal state. But there are certainly plenty of clinician reports indicating that precipitated withdrawal may be worse with buprenorphine initiation for people using fentanyl due to the higher potency and tolerance of people using fentanyl and the lipophilicity. There's, however, large-scale studies so far that there's a few, at least, that do not support that there is this increased risk of failure using buprenorphine for fentanyl use disorder or precipitated withdrawal. And that this data also includes a recent prospective clinical trial of 1,200 people. So it's possible we just have to identify the optimal ways of using buprenorphine. We're not in a position, however, yet to say what is the best approach. Well, there's a lot of research happening, and we do have evidence to support at least that higher doses of buprenorphine provide life-saving benefits. So this is showing the current FDA package insert, which importantly has remained unchanged since 2002, when fentanyl was not prevalent, and recommended a maintenance dose of 16 milligrams of Suboxone, and also stated that higher doses than 24 have not been demonstrated to provide any clinical advantage. However, this has really been changed over the past 5 years or so, at least. The American Society of Addiction Medicine, Academy of Addiction Psychiatry, other organizations have strongly recommended higher dosing up to 32 milligrams based on data supporting better outcomes, particularly with fentanyl addiction. So where did these earlier dosing recommendations come from? Earlier dosing protocols were based on PET imaging evidence correlating sublingual doses with mu receptor occupancy. What was clear from these PET imaging data was that there's significant intraperson variability in mu receptor occupancy using the same dose of sublingual buprenorphine, as shown by the red arrow. At higher sublingual buprenorphine doses, however, closer to 32 milligrams, there's less variability in mu receptor occupancy between people. 32 milligrams dose achieves near 100% mu opioid receptor occupancy. And then pharmacodynamic data has significantly contributed to changes in dosing recommendations for sublingual buprenorphine. I'm going to share one of my favorite models. It was developed and presented by Mark Greenwald recently, summarizing data on clinical effects at different mu opioid receptor occupancies. The percent of receptors occupied is on the x-axis. And so, his model showed with summarizing data that suppression of opioid withdrawal as a therapeutic target requires a wide range of mu receptor occupancy between people, anywhere from 20 to 60%. The whiskers show variability between individuals in terms of receptor occupancy. Suppression of opioid cravings has been found to be associated with an even wider range of mu opioid receptor occupancy with greater variability between people. And then in order to prevent drug liking with on-top opioid use, it would be helpful to decrease the reinforcement effects from using opioids on buprenorphine. So the blocking of drug liking appears to occur at higher mu opioid receptor occupancy. And to prevent illicit opioid drug seeking, a greater occupancy may be necessary, but very, very important in order to prevent respiratory failure while a person is addicted to fentanyl using it on top, we would need to cover 90 to 100% of mu opioid receptors with buprenorphine, achieve near maximal mu saturation to really feel comfortable about preventing an overdose with fentanyl relapse, which is very common. So in the blue is where we should really be aiming with buprenorphine doses according to pharmacodynamic evidence with harm reduction. I'm not going to go through all the studies. There's a lot of clinical data that's demonstrated clinical outcomes, improved retention, reduced illicit opioid use, improved patient perceptions about the adequacy of their dosing, pain control with sublingual buprenorphine doses above 16 and frequently above 24 milligrams. And I will included this because this is a wonderful recent literature review, summarized 17 publications supporting higher doses up to 32 milligrams. And multiple organizations have strongly recommended updating the FDA label to reflect the recent data. So unfortunately, the data on retention with sublingual buprenorphine, even at these higher doses, recommended doses for people in the era of fentanyl, has been poor. Less than half of people remained on Suboxone, even on higher doses in the first few months after initiation, according to this recent large retrospective review. But dosing high enough to achieve receptor saturation makes sense, but there's lots of variables we know with using sublingual buprenorphine still. So we know the bioavailability is very different between individuals. Absorption can differ threefold between individuals with sublingual absorption, and also there's great variability in the clearance of buprenorphine. Importantly, swallowing sublingual buprenorphine inappropriately instead of letting it dissolve under the tongue results in 90% of buprenorphine being eliminated. This is due to first-pass liver metabolism if it's swallowed. So this slide highlights the importance of giving proper instructions to patients to let the Suboxone or Subutex dissolve under the tongue. A useful suggestion that was presented at ASAM that I've utilized a lot because I thought it was really brilliant is to instruct the patients to keep their chin tucked to the chest while allowing sublingual buprenorphine to dissolve to avoid swallowing any of it, to just prevent loss of the buprenorphine. Many of the PTSD experiences with sublingual buprenorphine may very well be related to underdosing and or technique. And it's really, I think, important to explain to patients why it may not have worked. Explaining these things to patients has actually helped sometimes motivate people to retry sublingual buprenorphine. A common fallacy, however, in our dosing of sublingual buprenorphine historically has been focusing on peak concentrations with doses rather than troughs. And this is a study also done by Mark Greenwald, showed what happens to mu receptor occupancy in multiple regions of the brain, shown by these different curves after receiving a dose of sublingual buprenorphine. So the vertical axis shows the percent of available mu opioid receptors, which increases as the time passes towards the right on the x-axis. And then the blue frame highlights what happens in 24 hours after a sublingual dose. So after receiving a 16 milligram sublingual dose, 90% of mu-opioid receptors are occupied. However, within a few hours, less than half of the mu-opioid receptors are by the same dose. So if we were to focus on peak receptor occupancy, we would not be meeting treatment goals. More frequent dosing may help maintain drug levels, but a more stable dose of buprenorphine, such as with long-acting formulations, makes especially good sense now with the risks of underdosing buprenorphine and fentanyl-related overdose and high relapse rates. So 2 extended-release buprenorphine formulations have been approved by the FDA, RBP 6000 or Sublocade in 2017, and CAM 2038 or Brixadi in 2023. Both of these are administered subcutaneously. Both come in monthly preparations. Brixadi also comes in weekly preparations. Importantly, Sublocade was approved for starting after 7 days of sublingual buprenorphine for achieving a steady state and evaluating dosage needs. Brixadi was approved for initiation after a single dose of sublingual buprenorphine. Brixadi also allows for more sites of administration, which does become important. Certain patients would not like to have the visible drug in their abdominal fat. So Brixadi can be administered in the thighs and arms, in the back, in the butt. We don't have data comparing outcomes between the 2 extended release formulations. But importantly, weekly Brixadi was approved by the UCSD Hospital Pharmaceutical and Therapeutics Committee, so it will be available for our institutions in inpatient. In dosing injectable buprenorphine, it's also important to think about what our goals are with plasma concentration. Certain plasma buprenorphine concentrations have been identified as useful targets. So a plasma buprenorphine concentration above 2 nanograms per milliliter appears to be a level at which respiratory depression is blocked for most people when using opioids on top of buprenorphine. This is a concentration achieved by both low and high dose extended release buprenorphine formulations. In order to suppress reinforcement or reward from illicit use, opioid use on top of buprenorphine, and decrease relapse, a wider range of buprenorphine plasma concentrations may be needed. So this graph shows drug liking scores on the vertical axis and plasma buprenorphine on the x-axis, and the circles show variability in concentrations between people. But 5 nanograms per mil appears to be a plasma buprenorphine concentration that prevents opioid reinforcement on top of buprenorphine for most people. This slide is really important. It shows not just the peak plasma concentrations or Cmax or average plasma concentrations, but importantly how the trough plasma concentrations vary between different buprenorphine formulations. And you can see that high dose extended release buprenorphine at the 300 milligram level gets a gold star for meeting the 2 nanogram and 5 nanogram mil thresholds, even at its trough levels. So in general, the extended release buprenorphine formulations do achieve higher and more stable buprenorphine concentrations than sublingual preparations. Also shown here is what happens over months with more doses of high dose extended release buprenorphine. This is a graph of Sublocade doses, but each month the dose causes a spike in plasma buprenorphine. As you can see, there's the troughs and the peaks increase with every monthly injection and don't reach a steady state for 4 to 6 doses. So it is a common practice to offer sublingual buprenorphine to use as needed on top of extended release buprenorphine, especially while steady state is being achieved over months and according to individual benefits with the low risks of harm. So what about any data comparing outcomes with extended release buprenorphine and sublingual? So the data is limited, but certainly growing fast. There's been 2 randomized controlled trials. One of them notably included the largest sample of people using fentanyl, with 111 participants using fentanyl, and extended release buprenorphine was associated with a higher percentage of opioid negative urine drug screens in months 1 to 6 compared to even high dose sublingual buprenorphine. In this study of note, also 5 participants had non-fatal overdoses, and all of these cases were in the sublingual buprenorphine arm. Another RCT in the UK compared abstinence among people using extended release buprenorphine, sublingual buprenorphine, and methadone as well. This study found that participants on extended release buprenorphine had significantly more days of opioid abstinence and longer treatment retention than people on sublingual buprenorphine or methadone. This is a retrospective study. It looked at treatment retention post-incarceration in 52 people, showed that retention at 2 months post-incarceration was nearly twice as high in people on extended release buprenorphine compared to the sublingual group. And then finally, really, I think, memorable paper worth mentioning today was a recent retrospective study of 379 people with opioid use disorder, which evaluated overdose events after initiation of medications during the first 6 months, and showed that extended release buprenorphine was associated with significantly lower rates of overdose events compared to both sublingual buprenorphine and methadone during the first 6 months after initiation, which really correlates with the pharmacodynamic data. So now that I've discussed the evidence for dosing and formulation, I wanted to briefly review different strategies for initiating buprenorphine. Importantly, we don't have the clinical trial data yet to say which is the best initiation strategy for a person with fentanyl use disorder, but it is ongoing. So this is a summary slide of initiation strategies from the American Society of Addiction Medicine that's been published recently. And so I'll kind of go through them, but standard or classic buprenorphine initiation, this is the oldest approach that's been used and studied. It was used extensively before fentanyl was prevalent. And this approach recommends waiting for moderate severity withdrawal, so cows of 8 or more usually, to occur in order to avoid precipitating withdrawal. Giving 2 to 4 milligrams every 1 to 2 hours and titrating up over 1 to 3 days to maximum dose for comfort. So common challenges with this approach include that many people don't want to go through any period of withdrawal. A patient in acute pain may not tolerate the opioid-free period. Many people have failed initiation attempts with this approach. We may not achieve therapeutic target concentrations of buprenorphine quickly enough with this method and may lose people in the slow up titration. Low-dose initiation strategies attempt to avoid precipitated withdrawal by introducing buprenorphine gradually while a person is continuing a full opioid agonist. Some people have called low-dose initiations microdosing. Well, we're not actually using microdoses. But the full agonist is recommended to be continued throughout the process of increasing the buprenorphine. Makes most sense to continue it at the same dose, so there's less variables affecting the withdrawal state. But this strategy makes great sense for people who are hesitant to stop opioid for any period of time, or who are having acute pain in the hospital and transitioning off of full agonists. People who've had a history of failed standard or high-dose buprenorphine initiations, and people trying to transition off of long-acting opioids like methadone, which require slower tapering to even to subtherapeutic ranges prior to stopping. So the evidence for low-dose methods is largely case reports. While there is a lot of clinical experience with this, variable dosing regimens have been published and used successfully with different rates of up-titrating the buprenorphine. Low-dose buprenorphine starts often require off-label use of formulations that are approved for pain, like buccal films, Belbuca, and transdermal patches. Suboxone of note comes in a 2 milligram dose at the lowest dose, and we're not often allowed to cut strips in a hospital. But low dose transitions may be more feasible to do in a hospital setting where we have the ability to it's definitely been done successfully outpatient, but in the hospital we have the ability to prescribe a full agonist and monitor a person who's using fentanyl, where it may be more difficult if they're using fentanyl on the street or as an outpatient with more variables in the transition. But in the hospital, short-acting opioids like hydromorphone and oxycodone have frequently been used as the full agonist inpatient with low-dose initiations. And some protocols have used fentanyl or methadone as well while up-titrating buprenorphine. What we know is that people who are using fentanyl have a high opioid this strategy. And people will require higher than usual doses of full agonists. So oxycodone, IR 20 to 30 milligrams every 3 to 4 hours, or hydromorphone 2 milligrams IV every 3 hours would not be unusual. Really important things to prioritize is frequent communication with the patient to see how they're doing through the process, their comfort through the process. And this can be done for inpatients perhaps more easily, but again, certainly has been done even for people who are unhoused, but with frequent follow-up. There may be times where we need to slow down increasing buprenorphine dose or pausing it. And in the outpatient setting, to help people with the protocols for titration for buprenorphine, blister packing or pre-filling boxes have been useful. So lastly, I'll discuss macrodosing or high-dose buprenorphine strategies, which is Yeah.
Sorry,
Yeah.
just really quickly. I said that I'd save a question for the end, but I think probably it's a good time now if you're all right as you're taking
Sure.
a turn into something else. Nettie asked when you were talking about the different formulations, if there could be any psychosocial confounders in the comparisons between them, because she wonders if folks with more resources have better access to extended release products.
Yeah, so it's interesting. We're fortunate in that recently Medicaid actually covers all the extended release formulations. So that has not, insurance coverage at least has not been a barrier. But I will say a big barrier is that it's not stored in a lot of places. So if a person is coming in requesting it, or for example, Brixadi, which can be given same day, if it's not stored, you lose some of the effectiveness there in a way first, because the person may never come back. So I think that's been an issue more, like accessibility with storing the drugs, and that's a process. But not like insurance coverage. In terms of other, I mean, there's always psychosocial, I think, determinants of getting to treatment. But yeah. Fortunately, it's not been with the availability that way. I think actually, interestingly, some private insurances might be more challenging now with that. But yeah, overall, we haven't
Right,
struggled
like
too
so many things, right?
Yeah, actually had a private insurance.
We did get at least Sublocade on the ADAP formulary for those who don't have access to Medi-Cal.
I'm actually going to talk about how to get, and yeah, locally for our patients. So that will hopefully be useful information. But
And one more question from Shannon before you go into the high dose options. Do you think using fentanyl for agonists instead of oxy or dilaudid in these patients with pain is a good strategy since there is strong mu affinity, or is that counterproductive?
No, it is. It actually has been used successfully, and was certainly talked about a lot at the addiction medicine conferences, that makes the most sense for somebody who's got a higher opioid deficit. Yes, certainly. But I know we're uncomfortable doing that, of course, and we would need it would be helpful to have pain medicine involved, I think, especially inpatient with that. Okay, so I'll
sorry,
continue.
you're good now. Thanks.
I'm excited for the questions at the end. So I will discuss macrodosing now, and this is actually included in our new substance use disorder epic order set, which was created by the Opioid Use Disorder Task Force recently. Similar to the classical approach or standard approach, this is an approach attempted when someone is already in withdrawal. And the rationale for this approach is to move as quickly as possible from displacing the full agonist, getting through withdrawal, to achieving the agonist effects of buprenorphine. The difference between this and classical or standard approaches is that the goal is to achieve those high buprenorphine levels as fast as possible, and often using upwards of 12 to 32 milligrams or more on the first day. So due to the increased opioid deficit needing to be addressed with chronic fentanyl use, many experts have suggested always using a high dose approach in people using fentanyl, but this doesn't mean not using low dose approaches. It's basically, how are we addressing the opioid deficit? So that should be the goal. And this can be done by either using high dose buprenorphine or low dose buprenorphine with a high amount of full agonists to meet this deficit has been suggested. High dose initiation strategies start with 8 to 24 milligram doses of sublingual buprenorphine, go up by 8 to 16 milligrams as needed every 30 minutes to 2 hours, because that's the time we could expect to see the peak effects of it, all the way up to 32 milligrams if needed on day one based on patient comfort. People have certainly gone higher than 32 milligrams based on patient's comfort level, recognizing that there's intra-individual variability, but we really don't know the optimal max dose yet. So different high dose initiation protocols that have been used successfully are listed here. All are used when a patient is in moderate or severe withdrawal with CALs of 8 or greater. The high dose approach has also been employed after naloxone reversal, when more mu receptors are vacant. And extended release buprenorphine formulations have certainly been given when patients are in withdrawal or after an overdose as other examples of macrodosing. I wanted to mention this really exciting trial that's actually ongoing. that is across 28 ERs across the country that's comparing retention with immediate initiation of weekly Brixadi without preceding transmucosal buprenorphine to high-dose sublingual buprenorphine in 2,000 people using fentanyl. We actually have important data from this study already that shows that there's a low incidence, a very low incidence of precipitated withdrawal with immediate initiation of Brixadi at a dose roughly equivalent to 16 milligrams of sublingual buprenorphine. And the investigators also importantly started Brixadi in many of these patients at cows of 4, indicating mild withdrawal, not 8. So even with the cows of 4 in people using fentanyl, that overall there was less than 1% rate of precipitated withdrawal in a large patient sample. And this starting dose of Brixadi that they used as well was higher than the initiation recommended in the Brixadi package insert. The slow rise in buprenorphine over 24 hours with the weekly Brixadi compared to rapid peaking of buprenorphine with sublingual dose is suspected of helping with a more comfortable displacement of fentanyl. Most of the precipitated withdrawal cases in the ED innovation study were in the sublingual buprenorphine arm. So then before I conclude initiation strategies, I think it's really essential to talk generally about treatment for precipitated withdrawal. We should always have a plan for addressing it, even before it starts. So recommended first-line treatment is opioids. Using adjuncts throughout the process certainly can help after addressing the opioid deficit as much as possible. Alpha-2 adrenergic agonists like clonidine and lofexidine can relieve autonomic symptoms of opioid withdrawal and have strong evidence for this effect. Other supportive medications can be used per usual for diarrhea, nausea. Small doses of benzodiazepines have frequently been used and helpful while you can monitor for oversedation, particularly with inpatients. And then here's a shared decision-making tool that has been developed for helping choose the best initiation strategy to start for a particular patient. It guides the clinician with a script, actually, for explaining the different buprenorphine initiation strategies to patients and also requires soliciting their perspectives in the decision-making. And this is available at easymoud.com. It was presented at ASAM as well. I wanted to end with talking about linkage again, because when we look at inpatient initiation of sublingual buprenorphine, the important mortality benefits have not been seen without linkage to post-discharge treatment. In fact, it's really important, I think, to recognize that there's a particularly high risk of mortality after a hospital discharge, while people often lose tolerance while sitting in the hospital. In a study looking at the timing of opioid overdose deaths, the highest risk period of overdose death was in the first 2 days after leaving a hospital. And the risk remains very high during the first 2 weeks after leaving a hospital. So outcomes of inpatient initiation of long-acting buprenorphine on overdose rates are being evaluated in ongoing trials and will be very helpful to learn. So for starting weekly Brixadi inpatient and a patient wishes to continue treatment, we are responsible for bridging them to follow-up care to prevent death. The options do depend on a patient's insurance. As I mentioned, we're fortunate that Medicaid it does cover all of these options, but it may be trickier with other insurance. Most of the time, it's not been according to other providers who see patients more with private insurance. But on our new Pulse website, there are documents of where to link people based on insurance and other factors. And this will be listed under the addiction medicine and community resources sections on our Pulse website. Also very important is that different options are offered at different sites. Very few offer all of the FDA-approved options for patients. And then in particular for prompt transition to monthly extended release buprenorphine, there's a page in the linkage document of local pharmacies where people can now get extended release buprenorphine or naltrexone on the day of discharge. And the site should be identified at least 24 hours before the day of discharge to ensure that insurance has authorized the drug and that the pharmacist at the site is aware. But Vaughn's, Pavilions, and Albertsons are local sites of administration where we've been able to get people, they have Sublocade only, not Brixadi currently, but they're going to get Brixadi, but Sublocade and Vivitrol, been able to do it within 24 hours or on the same day even. There is a web link on the guide that connects to the page shown where you can put in the area code to find other pharmacy sites for administration of long-acting treatment. Even if a patient is scheduled to receive these medications at discharge, they must have a treatment provider to continue the prescriptions with. So it's really important to also look at, I think obviously very important to figure out where the patient can continue treatment prescription with outpatient, inpatient, other treatment programs which are in the linkage resources. There are 7 comprehensive treatment clinics under Acadia in our county where people can get all of the FDA-approved options. They can see a prescribing clinician, a drug and alcohol counselor, get social work support. And but it's important to look at the time of closure for different clinics. If it's a methadone clinic, it often will close early, has to close due to federal regulation, usually by noon, I think, or 2 p.m. at the latest with some of the Acadia clinics. I recommend looking through the resources to familiarize ourselves with them before we have a patient who needs to be linked quickly. We need to, I think, also know the lower barrier options, as many of our inpatients don't have easy access to phones or transportation when they leave. And then some exciting news is that the Opioid Use Disorder Task Force at UCSD created an order set for substance use disorder treatment in general, which updated one that was available for opioid use disorder from a few years back. And the current UCSD EPIC order set includes high-dose buprenorphine initiation and methadone starts, but will also include Brixadi, and it is a work in progress. There should be more system-wide guidance. We were talking about a video being made to help with how to use it in the near future. So hopefully some memorable concepts from today will be that higher dose buprenorphine provides greater insurance for meeting therapeutic targets, including prevention of illicit opioid use and overdose. We should offer extended release buprenorphine, especially with the data supporting better retention in comparative randomized controlled trials that we have so far, and likely better protection from overdose. And then current recommendations in terms of initiation strategy are really to individualize the initiation approach and offer the evidence-based options. We also need to prioritize a plan for treatment continuation when we start treatment in patient, and recognize that mortality is actually highest when a patient leaves the hospital. And that's all I had. I actually have a lot of extra slides if people have questions in case for help.
Thanks so much, Amu. There are a few questions. And Shannon makes a good point. Y'all know that the speaker usually can't see the comments, so I'd love for people to unmute. Dave, are you able to unmute? Because you asked a few questions. One was related to a study.
Yes, and I didn't want to interrupt. I'm not
I know.
Dr. Blumenthal, I'll leave all the interruptions to you.
Exactly.
But first off, Amu, I am just so bummed that you're moving on, but so happy for you. It's such a great opportunity for you. And I'm taking this opportunity to ask all my questions, but I can't promise that I won't reach out to you in the future for these answers as well. But so this isn't really my field, but we were really discussing the use of dilaudid oxycodone for pain in the inpatient setting. And I'm just wondering, if people have opioid use disorder problems, why not just start putting them on buprenorphine for pain? Clearly, I guess you can't do it parenterally, but I don't know how many people are getting oxycodone parenterally. So, that's one question.
Yes. So we actually do have we have IV buprenorphine, Buprenex available in the hospital. You just don't use it. Yeah. And it is certainly being used first line, actually, buprenorphine for pain in the hospital. But just we need to start it. At the VA, there's actually wonderful guides, even the VA in La Jolla, for using buprenorphine for pain, and actually how to do the low induction to help people get off of full agonists. And with all of the neuroadaptation, benefits using a partial agonist, et cetera.
Okay, excellent. And then my other questions, the ED study that you had mentioned. I mean, because honestly, I have always thought, why not just, give somebody a long-acting drug right away? There's going to be less precipitated withdrawal as it kind of slowly makes its way into the receptors. So this ED study actually that you mentioned, is just straight
Mhm.
off the 1 week buprenorphine formulation. It's not, there's no test dose, no sublingual test dose. Yes, okay.
Exactly. And
So
that's
you-
what I'm like, that is so exciting, like for everyone. Hopefully we'll have that data in 2025. That's when it will conclude. But it's wonderful because it's also across the country, 28 ERs and 2,000 patients using fentanyl. Very valuable data. It'll be looking at retention and cost of, I think they might be including cost effectiveness data, but you know, other data, including overdose, I'm sure.
And then one last question, just a clarification. Are you sure that these long-acting opioid, buprenorphine formulations are a Medicaid mandate? So the federal government has said all states with Medicaid must put this on their formulary? Or is it just that it is under our Medi-Cal formulary? And then it may not be something that is at every state. Because when I went around asking folks about long actings in different states, many of them said they didn't have them on their formularies, but these people weren't necessarily also testing that, so many of them probably didn't know.
So first of all, I want to say that I did misspeak. I should have said Medi-Cal, and we do have a pharmacist here. Maybe they might actually know. I don't know outside of our state, but I know that for sure in Medi-Cal covers it. I thank you for correcting me on that. Yeah, I don't know about
You mean our
whether
pharmacist of Shannon? Is that who you're poking at?
no. I
Or
see
other folks?
Christians. I don't
Does
know. I
anyone
don't
have
put you
any
on.
thoughts? Oh, Lucas too.
Uh,
Lucas
okay,
said,
there's
sorry,
Lucas.
no microphone, but I don't
I
know
can't
about
say
other
that I
states.
know the answer to
Oh,
that
good.
question.
And I thank you for making that distinction. I didn't realize I kept saying Medicaid. I meant Medi-Cal.
Thanks.
Thank you. Yeah.
There was another question sort of globally. For everyone, we have I think if you want the slides specifically, you'd always have to reach out to the speaker directly, but all of our high rounds talks are on a UCSD AVRC website. So if you just like type in UCSD AVRC high rounds, it
Yeah.
takes you to, yeah, sorry, go ahead.
Yeah, Jill, we have a YouTube channel. So,
Right.
and all the weekly reminders through the link to our YouTube channel. So if the presenter gives me permission to record, then I post them. And so if they're not up there, it's because I didn't get permission to post that.
So if you
I
don't,
also
and
wanted
it
to say
usually
that
takes what, about a week for you to get it up there?
Like a few
So,
days.
yeah. So if you don't see it, that would mean you'd probably have to reach out to the speaker directly if if you want access to the PowerPoint.
this is going to be put on Pulse as well. Fortunate, thanks to Marvin with helping me. We talked about it before. I also wanted to mention that there's going to be more grand rounds on like alcohol use disorder treatment updates, as well as stimulant use disorder updates, which should be hospital medicine grand rounds next month. And I'll be helping with that as well, but that will be recorded as well, and they'll all be on Pulse. And I believe my slides will be available too. Yeah.
I think I went through all the questions on the side. Oh, yeah, no, I think I did. Shannon said this talk should be added to the health system required competencies. These sorts of talks may be in the future. I don't think we're there yet, but I don't know if Amu, you have any thoughts around that and sort of mandates for providers and what, obviously the X waiver is gone now, so where are we moving with all of this in general?
I think what's going to be so great is that with the order set, for substance use disorders in general, it will hopefully, we'll be looking to see, how does that improve prescription rates? But I think it will, because it provides the guidance in initiating treatment. And then people can always refer to the Pulse website now with like the different options, and hopefully we don't make it too confusing, right? So that you could easily find what you need. Oh, someone had mentioned commenting on management of OUD and pregnancy. Absolutely.
That
Yes.
could be a whole talk, right?
Yeah, I actually am doing a small one. I'm doing one for that, for OB, in the end of July, but basically the doses are so methadone and buprenorphine both recommended first line options. Naltrexone not in pregnancy. Unfortunately, the extended release options are not approved for pregnancy, and that's due to not the buprenorphine, but the vehicle, which has N-methyl-2-pyrrolidine, which has some effects in animal studies. Yeah. So, but anyway, that hopefully will become an option in the future without that vehicle. Point is, the doses need to be higher in pregnancy. So don't hesitate. Actually, there was a patient who was pregnant in the hospital who was actually, they were more, like people were more concerned, afraid to dose buprenorphine in her, but actually should have been higher. And the reason is there's a lot of physiologic changes, such as more rapid clearance, and also higher, what do you call it, plasma volume and lower concentrations of the drug. And then we also have differences in our metabolism of buprenorphine otherwise that and methadone that contribute to requiring and recommendations for higher dosing in women who are pregnant. Also, more frequent dosing due to the more rapid clearance, so split dosing to maintain drug levels. Someone had Subutex in there, and I'm really glad you brought that up. Yes,
For
yes.
pregnant women, right? Because it's
no, so Suboxone can be used. Suboxone can
okay.
be used. Yes, that's more recently also recommended. Yep. Thanks for bringing that too. Yes. Suboxone certainly can be used in pregnancy as well. And there's data now to support that. But as far as the Subutex in general, I think it's really important for people just to be aware that that is actually a great harm reduction option if someone doesn't want to be on Suboxone. The concern with Suboxone or Subutex is that it's a mono product, it's buprenorphine without the naloxone. And so, there's evidence that there's less diversion when you combine naloxone with buprenorphine, because then people will not inject or snort the Subutex. However, there's actually recent guidance on this. The provider clinical support system has a new information to talk about using monoproduct or Subutex and Suboxone, and recommends, yes, using monoproduct when a person doesn't want to use Suboxone, because there's more evidence that we have variable absorption of the naloxone component, which has widely been considered not to be absorbed well sublingually, which is why we can use it in Suboxone sublingually. But there may be clinically relevant levels of naloxone absorption with Suboxone, and so people may have different effects with it. And so it is recommended as a second line alternative option if someone doesn't want to use Suboxone.
Thanks, Amu. It's 9 o'clock, so I just want to respect people's time. Laura Bamford noted that there was a tip sheet for the order set created that will be published in EMR News this week. And for those who don't read EMR News, it's great. It's really very helpful. It gives you a lot of, epic tips. And there's an order set called Inpatient UCSD Substance Use Disorder Management. So that'll be helpful on the inpatient side. Shannon asked a question about the emergency room and will they start embracing this issue? I think you can make a comment about it, Alma. This may be the last thing that you say, and I'm sure it's not a long answer. I'm sure it's not a short answer, but if you can make it brief, I don't know where you think things are with that. And then that will be that. And we appreciate you.
I'll give a shout out to Richard Clark. I don't know if he's on here, but he actually he's very excited about it. He actually was telling me we should be studying this together, the outcomes after we start it here. So, I mean, he certainly helped with getting it approved, being on P&T.
Well, thank you, Amu. I think this is obviously a great, God, I'm going to start crying again. No, I'm okay. I'm good. No, I think this is a wonderful way. We did not plan this, that Amu would be speaking, soon before her departure. But again, I want to share a very heartfelt thanks for all the work that you've done I can't do this. Never mind. I'm just too raw right now.
Oh, you're good.
You're incredible, and you know, we're really, I think the sentiment is we're sad that you're leaving, but so excited for this new opportunity for you. So thanks for everything, Amutha. And to the rest of the group, we are taking a little summer break. So everyone gets a little vacation from seeing us, from obviously seeing me cry and things. And we'll be back at the beginning of August. I know we have Dr. Grilati giving a presentation early in August, but I don't know about the rest. So enjoy it. Thank you for being here with us this first half of the year, and we'll see you in a month. Thanks, everyone. Have a great day and weekend.